I'm going to narrate the case of your friend. You found a case which is not only a case demonstration, but it's a representative case for 20% of all breast cancers. This is your friend, a young woman, 2 beautiful children, and she came to your hospital, and you would like everybody go through what happened and whether her disease could have been stopped, because you don't feel good about that she is practically dying. So here is the story. She came with bloody nipple discharge from the right nipple. Clinical examination of the breast showed thickening in the upper central portion of the breast, and you could see the nipple discharge. A large area corresponding to a lobe has microcalcifications with no associated tumor mass. When we do photographic magnification, these calcifications, many of them anyway, are actually long. And we radiologists read pathology in a way that when the calcifications are long, then they are localized in major lactiferous ducts. And they are very close to each other. This is abnormal. And then there is calcification practically all the way down to the nipple. Now, any well-trained radiologist knows that this disease we call cancer of ductal origin, DAB, occupies a much larger area than what we are able to see and visualize on the mammogram. MR would show more, but MR might not show these near the nipple ducts full of cancer. And here is her CC projection. Once again, we can see localized to one lobe. And here is the microfocus magnification. Now we have a very good understanding about this being a cancer originating within the major lactiferous ducts called DAB. So, dear colleagues, let me take you through the sequence of events. At the age of 41, she came because of the discharge, because of the thickening, and the 14-gauge core biopsy showed so-called invasive ductal carcinoma, which looked like a very good cancer because the immunohistochemical biomarkers were very favorable. And because of this diagnosis, surgery took place. Unfortunately, skin-sparing mastectomy, but I understand the surgeon because this is a young woman. And a colleague, the pathologist, described the finding, a 15 by 11 millimeter carcinoma, which, however, was associated with comedocarcinoma in situ. Now, the total tumor extent was assessed by the pathologist to 3 by 2.5 centimeter. Dear colleagues, mammography, images, histology. Would you say that this is 3.5 centimeter? And I already mentioned to you, the disease is much more extensive than what we radiologists can see. So this is my first very important note regarding the pathologic workup. This patient had biomarkers that were identical with the core biopsy results, that is, ER positive, PR positive, HER2 negative, and low proliferation index. Here is my second comment. Could the colleague, the pathologist, tell me where the immunohistochemical biomarkers were determined from? From the acinar adenocarcinoma of the breast, that is, a stellate lesion, a circular lesion, originates from the acini of a terminal ductal lobular unit. So it's not a ductal carcinoma. Second, the immunohistochemical biomarkers were determined from the cancer cells localized within and distending the ducts and its branches. Question mark. Dear colleagues, I tell you something. All over the world, pathologists make this mistake. So therefore, the HER2 is going to be negative. But let me tell you already in advance, had the pathologist squeezed out the cancer cells from the distended duct, the DAB, not the AAB, then in 92% of the cases a HER2 would have been positive. The colleagues, the oncologists, got the message that this is a pretty good cancer, hormone receptor positive, very much localized to the breast, no node positivity, so she gets tamoxifen treatment. Excuse me? The cells within the ducts are stem cells. So basically one only treated the acinar adenocarcinoma of the breast, not the ductal adenocarcinoma of the breast. And let's see the consequences of this. It didn't take a long time. December 2017, October 2019. She got a recurrence. Final aspiration proven. A month later, she goes through simple mastectomy. Interestingly enough, histopathology shows a poorly differentiated breast cancer. But still ERPR positive, HER2, and a very aggressive proliferation index. The sad thing is, which shocked everybody, the diagnosticians and the clinicians, that 7 out of 8 surgically removed lymph nodes had macrometastasis, had extranodal infiltrating cancer. The disease progressed enormously, although the PET was normal at this time point. Then in April 2020, the patient went through all these cruel treatment and also much radiation. Unfortunately, about a year later, the CT reveals hepatic, bone, and node metastasis. PET scan, bony skeleton, metastatic deposits. This is my topic. The ducts are originally pleated, measure about 0.1 millimeter, 100 micron. They are a little bit twisted as well, as you see here. There may be fluid production in a TDLU, and this inspissated fluid may just stagnate there. This is alkaline, the water gets absorbed, and then we got a bar here, so-called plasma cell mastitis type calcification. Secretory disease because it's a result of secretion. It's just beautiful. This is mostly for the radiologists. There aren't too many other benign type calcifications localized within the duct. They are easy to diagnose, so let me talk about malignant type calcifications within the ducts. And once again, it may be so that the cancer cells have this micropapillary proliferation, and then they are dripping, producing fluid, just like in the TDLU, and the fluid is going to distend the duct, and is getting ever more concentrated amyloid body within which these flat stone-like or pearl-like calcifications are formed. And these are very difficult calcifications for the radiologists, and here are the pearls within the side branches. But this is my topic, fragmented casting or snake skin-like dotted casting type calcifications. This is the normal duct and the TDLUs in three-dimensional histology. And here are these ominous calcifications that look like a bar, and they have their side branches, and there are too many. That's unnatural. So that already tells me that when the colleague, the pathologist, is going to call this DCIS, that's not correct. It may be so that the tumor cell proliferation is micropapillary, and still there is necrosis. So the tip of the micropapillary cell proliferation breaks off, and it ends up in the lumen as tiny dots. We know this. The important thing is that I look at it, and this is DAB. Here is the problem. Don't call it DCIS. 30% of the patients die when I see these things on the mammogram. I'm not talking about histology, because then it would be a shame that the patient gets DCIS diagnosed and she dies. So these so-called imaging biomarkers, mammographic appearance, are much better predictor of the poor outcome than any histology. So we have a problem with histopathology and we have a problem with TNM classification, as my case showed. If I may ask a question, here is a 3 to 5 centimeter acinar adenocarcinoma of the breast, and here is a smaller than 10 millimeter. You know, it's shocking, isn't it? That both of them are going to have very poor outcome. Now, how come that this little one and that have equal outcome? No, comparison is wrong. And that's where the pathologists are wrong, because they determine the HER2 from here. But look, this is a huge tumor burden. So the massive tumor burden here and the massive tumor burden here give the very similar long-term outcome. Think about it. You see, it really doesn't matter whether it's small or large acinar adenocarcinoma, let's call it circular stellate lesion, is associated with the so-called casting type calcifications that are so easy to recognize. This is running the show, not this. Why? Because this is duct-forming invasive carcinoma, neoduct genesis. Originally, the duct looked like this, and now it is distended, but it formed a side branch, like cacti do, like a bush or a tree. So it results in tightly packed, tortuous, abnormal duct-like structures, distended by aggressive cancer cells. We call it new duct formation, neoduct genesis. And here it is, dear colleagues. Normally, a duct has one function: to carry the milk to the mouth of the kid. But this duct doesn't exist anymore because it's full of cancer cells. As you see, it's micropapillary, and it drills a side branch. And there's a side branch, and these are lymph vessels and blood vessels. That's why the LVI positivity is an important prognostic factor. It may be node negative, but she dies because it breaks itself into the bloodstream, lymph stream directly. For the pathologist, it's here. Here are the side branches, disorganized structure, and the other very important prognostic factor is this very thick desmoplastic reaction. Don't be fooled. These were cancer cells one day. They transformed. The epithelial cells became mesenchymal cells through transition. Remember, EMT. Very thick lymphocytic infiltration, very thick desmoplastic reaction tells me that this is an invasive carcinoma. Here it is, desmoplastic reaction. The cancer cells are here. And here is lymphocytic infiltration. I'm sure all of you can follow this one. The duct and its branches are drilling. This is a normal duct. These are cancer cells. And what is this lymphocytic infiltration, desmoplastic reaction? That's invasive carcinoma. And neoduct genesis can be seen anytime, anywhere, especially in hot and humid countries. Side branches are growing. That's not the original. So you cannot call it in situ. Comparisons with cacti see the extreme desmoplastic reaction and lymphocytic infiltration, and there are no associated TDLUs. This is all made by cancer. Proof? Yes. There is an immunohistochemical staining method, it's called tenosyne. When you see tenosyne overexpression around a newly formed duct, then we all understand that these cancer cells drilled themselves through the basement membrane and form new branches. Here we go. Tenosyne is a beta-glycoprotein produced at the sites of epithelial stromal interaction. Dear colleagues, it's a sin to call this in situ. And that happens with a patient I just demonstrated for you, had a relatively innocent 1.5 by 1.1 centimeter acinar adenocarcinoma on the breast. This one, stellate, circular, erroneously called invasive ductal carcinoma. No, it's acinar adenocarcinoma of the breast. Mistake number 1. Mistake number 2, that she had a massive tumor burden caused by neoductgenesis, duct-forming invasive carcinoma. And this one is responsible for her distant mets and her soon-coming poor outcome. This is written here. But let me point out, as I mentioned already at the beginning, it's such a mistake that the colleagues, the pathologists, determine the biomarkers from the associated, more or less innocent, small invasive carcinoma. Why don't they determine from the other invasive carcinoma? This one, the ducts and the branches full of more aggressive cancer cells. Because in 92% of the cases, a HER2 would be positive, and that would make it possible to give her Herceptin, the only hope she has. But you see, because the colleagues, the pathologists, determined the biomarker from here, they were actually misleading the oncologist. And poor oncologist gave tamoxifen. That's a laugh. It's a stem cell carcinoma. What a fatal mistake. And of course, the surgeon was misled because they called it DCIS. So they downgraded a very aggressive carcinoma to DCIS. Skin-sparing mastectomy was carried out, and then the leftover carcinoma was so aggressive that it started to spread. This is what I was talking about. HER2 positivity would have given a chance to treat her with Herceptin. So the diagnostic and the therapeutic team members need to get acquainted with the breast cancer classification that takes into account the site of origin. And if you want to hear about it, please put this into your browser. 3 very different subtypes of breast cancers. And you can put in all your cases into one of these 3. And also the diagnostic and therapeutic team members should understand that we radiologists created a revolution. We brought about something new, the 3rd-generation prognostic factors. At the tumor board, you should ask for the mammogram and an intelligent interpretation of the mammogram. And am I going to operate an AAB? Am I going to operate a DAB? And am I going to operate a huge architectural distortion? And you will hear in the lecture that it has nothing to do with the lobules, even if the pathologists call it invasive lobular carcinoma. No, it's not. It's a cancer of mesenchymal origin. Can I kindly ask every tumor board member, young and older, to listen to this lecture? Everything changed. Radiology changed, surgery changed, oncology changed. Histopathology didn't change much. But a heartbreaking case should tell everybody in the team that we made a huge mistake, a series of mistakes, because we gave tamoxifen for a patient with stem cell carcinoma. Please don't ever call it a DCIS. It's an invasive ductal carcinoma with a poor outcome. And if you really want to know more about basic science that prove that the cancer cell actually penetrate the basement membrane, that's the way they are forming a new side branch. And invades, now if this is the word from basic scientists, invades, then you cannot call it in situ. So the epithelial cells become mesenchymal cells, that is the desmoplastic reaction through transition, EMT. And here you can read the article. And this is a sad story. Even if she's 33, she does not need as many ducts or duct-like structures as this one. This is a potentially fatal disease. And don't fall in love with the associated AAB. Fear this one. Don't call it in situ. This patient has one breast cancer that might jeopardize her life and has another breast cancer, which is innocent, in case we find it in 1 to 14 millimeter or smaller than 15 millimeter size. Other teaching points for the surgeons. When we radiologists present these calcifications to you, like in this case, then we are obliged to give you a microfocus magnification that shows more calcifications. But your job is then to take another 1.5 centimeter, which means mastectomy. Please, look at the central duct, the branches, and here are some very innocent-looking AABs. But all this is DAB. Surgeons always cut through these cases. What a shame. Please don't operate the calcifications. Operate the patient. This is what it looks like on a mammogram. I want to give you literature. You can take screenshots or whatnot. First, we described this in 2000 and 2004, and we wrote books about it. And Lana has a copy of the book. And we wrote many, many more books about it. Dear colleagues, my heart breaks because my friend is going to die. And we could have, and we should have done much better. I hope my lecture is going to help you to learn, to study, because none of you knew about neoduct genitals. The pathologist made a mistake, the surgeon made a mistake, the oncologist made a mistake, all because of the pathologist. And please look at the mammogram in this case. When they are long and branching and too close to each other, that's a DAB. Do very extensive surgery. And please understand, it's a stem cell carcinoma. Don't irradiate the poor patient. It's resistant to irradiation. And we have to have the justification for giving Herceptin. There is no other medicine. Don't give chemotherapy. Give Herceptin to these cases. I'd like to open the floor for discussion.